Welcome to another episode of the podcast series Rare. In this episode, myself and Mary Angels will be chatting to Professor Dian Donnai, Sally Hatton and Professor Andrew Reid. Welcome and thanks for joining us. And if you want to just kind of introduce yourselves a little bit, just so we know who we're here with. So if we start with Di, maybe?
Okay. Well, my name's Dian Donnai. I'm a clinical geneticist at St Mary's Hospital in here. I've worked here forever, since 1977, and Andrew and I will probably tell you a bit about our joint journey through genetics. But I started life as a paediatrician, and then I was always so interested in developmental disorders in children, which is why I got into clinical genetics, really from the very beginning. And it's been a most wonderful career. I couldn't have hoped for a better or more interesting or more rewarding career. And still in my mid-70s, I hate to say, I'm still working 2 days a week and teaching. I don't see patients anymore, except by special request. But that's what I've done.
So I'm Andrew Reid. I also work at St Mary's, but I'm a scientist. I'm a DNA man, basically. I've had a slightly odd career because I started out as an organic chemist, and then did a number of other things. But I, like Di, joined the department in 1977. And in fact, we've been slightly joined at the hip ever since then, haven't we? And it's been a really nice partnership between a clinician and a scientist. So I started the DNA lab here in St Mary's back in 1981, I think, because when I first joined the department in 77, there was absolutely nothing that you could do with DNA that had the slightest relevance to patients. But I was lucky. I hit it just at the right time, because round about 1980, the first things that were useful began to appear, and so we thought, right, we must start getting involved in DNA. I went to Leiden in the Netherlands to do a course on DNA analysis, came back here, set it up here, and it's grown ever since. And, again, like Di, I feel so lucky to have been part of this. I mean, I have now been retired for a long time. I'm even older than Di, but I would just hate to walk away from it. It's been so interesting and so exciting to see the whole field develop. And what I really like about it is that it's a combination of cutting-edge science, but there's human stories at the end of it, and there's families and people with problems. I mean, I really admire scientists who can spend their entire career working on the back end of some snail and find things that are biologically important by doing that. I think, yes, those are real scientists, but I'm not like that. I need some human interest at the end of it. And I've been so lucky in happening, more or less by chance, on this whole area of work.
Brilliant. And Sally,
my name is Sally Hatton. I'm a patient living with XLH, which is a rare inherited metabolic bone disorder. So I work for Metabolic Support UK, who are an umbrella patient support organisation, and I'm the Young Persons Project Officer there, so developing services for other young patients with the disorders. And I've also been the last couple of years developing some patient advocacy work. So I work with XLH UK and the XLH International Alliance, and also recently joined the youth group with the European Patients Forum. So just trying to raise a lot of awareness, really, of rare disorders.
Before we started recording, Sally had realized that Andrew was the person who discovered the XLH gene that creates her condition.
And there's a connection between yourself and Andrew, which we've just found out. Do you want to tell us? In the waiting room, which shows that we didn't do our research very well. But if you want to tell us a little bit, both of you tell us a little bit about that connection.
Yeah, so we discovered in the waiting room that Andrew discovered the gene, I think, is that correct?
Well, that's quite right, yes. Because back in the early days with DNA, I mean, I was always a university employee, so my job primarily was research. And back in the early days, it first became possible to try to track a disease gene through families, but it was very, very difficult to do. You required armies of dedicated postdocs to really work at it for years. So identifying the gene that goes wrong in cystic fibrosis, for example, was a tremendous, huge international effort, and we couldn't possibly do that. But I thought, I want to be part of this. And I thought, well, with XLH, we know it's on the X chromosome, so that narrows down your search a great deal and makes the whole project just about doable. And then, in order to actually do it, you need not the science, you need the families, because in those days what you needed was fairly large families where you could see who did and who didn't get the disease. And so you're absolutely dependent on having good clinicians and willing families. There was a bone metabolism unit in the Royal Infirmary here in Manchester. They had ascertained a number of families, and many of these families were willing to help with the research. And so that was how I got involved in XLH research. And after a couple of years of work, we were able to show that the XLH gene was at a certain position on the X chromosome. We still had no idea what the gene was, but at least we knew where it was. And then in order to try to identify the gene, which was still quite a big and difficult job, not just something for a sort of man and boy outfit like we were. So we teamed up with a number of other people in London and in Canada, and between us we identified the gene. And then, of course, it's really exciting. I mean, you know, as a scientist, to say, well, OK, we found the gene. We know what happens to someone when the gene isn't working, but what's it doing when it is working? So that, for me, was really exciting, and it was the first piece of proper genetics research that I did.
And that probably connects you to Di a little bit as well. Di, do you want to tell us about how your career started and then when Andrew came into your life, so to speak?
Well, I went to medical school in London. I came from a completely non-medical family, and in fact my tiny girls' grammar school in Shropshire didn't even do science, so I had to do science at the boys' school. So that was interesting. So I went up to the big city, to London, and to medical school, and the specialty I most liked was paediatrics, because I liked the professor. He was really interested in families and how a child with a problem fitted into the family. So that sort of shaped a lot of my career. But so after I qualified, I started working in paediatrics, and there were 2 or 3 children that I can still remember, absolutely can remember all of the details of them. One was a family that I can still remember which cot this child was in, who had a disorder of their nervous system, a condition called SMA, where their muscles didn't work because it was like the nerves that go to the muscles were becoming unhooked from them. And this is an inherited disease. It's one where both parents carry one copy of the gene and the child gets a double dose. And this child, I remember, was called Timothy, and he was the 3rd child born to this family with this, and the 2 other children had died, because children with this disorder, the severe form, usually die within their first year of life. Sure. And there was just nothing that one could do, but it just made such an impact. I'll tell you, that's actually come almost full circle now, because now there is a treatment for this condition called SMA. And so if you detect this condition early, there is a treatment, a gene therapy for this condition.
Right.
So that's absolutely magic. But that's 50 years later. Yeah. 50 years since I remember this family. Because, you know, the families want to know what the problem is, they want to know why it happened, and they want to know, will it happen again?
And I think that theme is still really relevant now. That's all the families that I meet in my community. All they want to know is why, what to do, and will it happen again. And once you know that, you feel quite empowered then, I think, because then you can kind of live, or your child can live their life however you guide that. But you need those three things. I think that's really right still now.
So that was, and I remember thinking when I was involved in trying to get some tests done on this child, I remember thinking, God, it would be fantastic if you could do this as a job. But of course, you couldn't do it as a job. There was no such job. And so I continued on in paediatrics and moved around the country after my husband, who was an obstetrician. And then eventually landed in Manchester, having sort of done paediatrics, but not quite knowing which branch I really wanted to go into, because I was really interested in developmental disorders. And then there was a job advertised. There was a tiny genetics department. There was no training program. And I think it was my husband sitting next to the guy in charge of this tiny department, said he was looking for a part-time married woman to do some sessions. So I applied to be a part-time. I didn't know whether you had to be part-time married or part-time but,
part-time woman.
Part-time woman. But anyway, I got...
Either way, it's quite appealing.
It was two mornings a week. And so I stuck the kids in nursery and stayed for 2 whole days every week, because it was so interesting. And I sort of got my feet under the table and realised this was where I was always meant to be. And within a year, there was the first training posts in genetics started. There were 3 in the UK, one in Wales, one in Manchester, and one in London. And so I got one of those first 3 training posts. And that was coincided with, and well, no, I think I can't remember whether it coincided with Andrew coming.
No, we've quarrelled about who came first.
Yes, no, well, I definitely came first. I started on my birthday in 1977 and had no desk or anything. And then I was told somebody from the university was coming. And so Andrew and I were both given a desk in the corridor side by side. So it was outside the chromosome lab, wasn't it? We had a desk side by side, and eventually we were pushed apart by a primitive computer, wasn't it?
Well, you had to establish some defensible territory. So I had this large computer terminal by which you, in those days, talked to a computer up at the university, which was called George 3, and with good reason, because it had fits of insanity, but it was what you used. So I established that as my first land grab within the department.
I've been, a bit touched by the idea that you discover the person who kind of discovered that gene, and I'm just wondering how it is for you to kind of be here now.
I think
what have you been thinking since this happened?
It's strange, really. I think because I have a completely non-scientific background and a non-scientific brain, and with something like genetics, I can't, like I said this to you earlier, I can't get my head around how you make those discoveries. Because with other disorders, if it's something like a disease or something attacks the body, it makes sense that you have your body and something invades almost. But with genetics, I think it's so core to who you are and the fabric of who you are, and how can science go in and pick that apart and figure it out. And I guess it's strange with living with a condition, because it is so part of your life and so part of who you are. And then it's like the work that you do. You say it was years ago and you've done so many other things, but then it's strange to think it still impacts on the patient community now and what we're able to do in terms of looking for new treatments. And it's sort of such a remote connection, but such a close connection, I think. And it must be interesting for you, I suppose, with your interest in the patient side, to think that it does have an impact. You sit in a lab for all those hours and it does.
Absolutely, yes.
It makes a difference.
Yes, I mean, I would hate to just see people as specimens or examples of some interesting genetics. No, I mean, they're real people, just.
Yeah.
How important is that, Andrew, families? Like, I know that you and I have worked together quite a lot with that theme of how important families are to your work.
Well, in terms of research,
or patients, or
now they're not so important. which has been a sadness to me, because I really loved it when, I would have large files with the pedigrees of each family in, and sort of notes of what we'd found out about each person in the family and how it fitted together. And I absolutely loved that. And from a pure laboratory point of view, things have moved on. Nowadays, if you get a blood or even a saliva sample and you extract some DNA and you shove it in a great big machine which churns out the total DNA sequence, and you then spend time huddled over your computer trying to look which of the many variants in that DNA sequence, because we don't have the standard human genome, there's no such thing. You and I would probably have 20,000 little differences in our DNA, and 19,999 of those contribute nothing to explaining the differences between you and me, and one does.
Yeah.
And how do you get from that 20,000 down to the one? Well, it's all pretty hard work on the computer. So nowadays, that's how you do it, and it's much less interesting than having families and knowing that somebody has this problem and they have 3 children, one of whom has it and 2 don't, and so on. So I'm slightly disappointed at the way it's gone.
What do you think this will mean for the future? What is missing? I can imagine the way you're talking about that is missing for you, but what do you think will it be missing for everybody, really?
Well, it's only missing if the technologists are allowed to take over. I think we just have to remember, and this is a thing which Di has always stressed very strongly, that you need the clinicians who are interested in the family, that it's not just a matter of some clever science and big machines. And I think there's quite an argument about that going on and how it will pan out. But certainly if people are allowed to see this just as a problem in DNA analysis, then the family misses out big time, and the people who do it miss out because they lack that interest.
Yes, I think I absolutely agree with that. I mean, I am and have always been for progress and for change. I think there's nothing worse than saying, this is the way we do it, this is the way we've always done it, this is the way we must do it. I think you've got to constantly change in the light of new knowledge, and particularly in the light of new technology. So that's my philosophy for our department, and I'm delighted to see that the leaders of the department have got very much that in their minds. So you have to keep up with science. But remember, we are a hospital department, we're dealing with people, we're dealing with families, and we have to tailor our service and our offer to these families in the light of the new technology. But the great thing about genetics is that we mustn't look inwards to the team. We've got to look outwards to all the other specialties now. And that's the great thing of genetics, is getting more purchase on many diseases to be able to do something about them. And you can't do things about it just within genetics. You have to work with cardiologists, with neurologists, with cancer specialists. You have to work with all sorts of ologists and to be able to offer the benefit. And that's partly why Andrew and I, old though we may be, are still hanging on in there. And Andrew is he's asked to talk in so many meetings, even cutting edge stuff in Cambridge. Andrew is always asked to talk about things because he can put over things and he knows the whole story of technology, almost from the beginnings of DNA analysis through to where it is now. And sometimes some of these young chaps that are coming in now, they know all the highly, highly technical stuff, but you can see them listening in fascination of where it all came from.
They have to learn, don't they?
Yeah,
really
and
do.
it's still filtering through. It's when I had my second child, I remember getting the results of the CVS test, and it turns out that my second child didn't have achondroplasia. So my genetic counsellor had to call me with the news, and she said, and it's always stuck with me this in terms of how that has filtered through, that the person in the lab I don't know what you call that person, but the person in the lab had got the results and knew our family and knew who we were and said, this is going to be a really interesting result for that family and it's going to have quite an effect. And I was told that, and it was really powerful to me because that really stuck with me, that somebody that was just doing the science part
actually
cared about my family and my narrative and how
Yeah.
you know this newborn was going to affect our family slightly differently in a wonderful way, but slightly differently. And that really stuck with me, and that shows that message is still filtered down, and that integration.
Yeah, it's so interesting to hear with the work that I do from a patient support perspective and metabolic support, and we talk so much about bringing the patient voice forward and bringing that into research, and we now help with recruiting patients into research in their conditions and building that relationship with the science side and the medical side. And it's so fascinating to hear it from that other perspective and how much of an impact it does make to hear from families.
We are listening to Professor Dian Donnai, Professor Andrew Reid, and Sally Hatton talking about the impact rare gene discoveries has on your life.
Is this particularly important here in Manchester? I don't know, you're talking like you kind of go to Cambridge to influence people. I'm not sure. Is this something that you kind of develop or maintain or push or sustain a little bit?
I think we've been good at it, haven't we? We're not the only ones, but we've done it well.
Sure. And then the greatest thing is we've got to know people in genetics, particularly in Europe, but beyond as well. It's such an international specialty, and particularly with rare diseases. I know we're in Purda now, so we can't talk politics, but you can guess. And you know, international collaboration is absolutely essential, particularly for rare diseases. But that's for research, but also for service, for developing patient guidelines, for developing patient international support group. You're involved with Europe a lot.
Yeah, definitely.
You've been to Sweden, haven't you?
Yeah, so I went this weekend, just gone for the XLH Alliance meeting, which was organisations from mainly Europe, but sort of worldwide as well, that support patients in their individual countries. And it's just fascinating because they're such small on the ground organisations, but then when we come together, a lot of the problems are similar and the challenges are similar and the things that the families are trying to change are similar, and it's so much more powerful to talk together about what is the message we're going to put together. And we're hoping to go to the European Parliament next year with to raise some issues. And it's, as you say, I think especially with rare conditions, it even just as a numbers game, you need to get those people together, and there's only so many people in each place, and it just is so much more powerful in making that point that actually when we do get together, we say the same thing, so we must be on to something, and hopefully that then helps with research and treatment, because we can say this is the reality and this is what we're dealing with.
These days, when a child or an adult is diagnosed with a rare disease, you know, in the old days, you used to make photocopies of things to give to patients. What's a photocopy?
With their eyes. Their eyes would always be blocked out. You know,
I've seen that recently.
I know, and their eyes was, and it always gets me. I know why it was, but it's always really good.
Can you say a bit more? I didn't understand.
So my image of pictures of somebody with achondroplasia when I was younger, or any literature, was kind of just the bodies, and then they would standing like that, you know, and then they would actually kind of block
their eyes.
The eyes,
like the medical picture.
and it was always
like
really,
a bank robber.
and I just do think it's really, you know, really dehumanises the kind of. So my daughter recently she's under Sheffield Children's, and she's got this long blonde hair, and she really loves looking at herself all the time. And they asked her to be part of the consultant he's writing a book. And he said, can I take a picture? And I said, you can, as long as you don't block her eyes out. Let them see how pretty she is. Yeah, you know. So I always remember that with the literature, that it was like...
But what I was going to say was... No, it's okay, because that was interesting too. But what I was going to say is that information is what people are hungry for when they're told something. And the people that can best amass the literature, or best amass the information that families want, are patient organisations. But they can't do it on their own. They've got to do it in partnership. So this is why the partnership between patients and between clinicians and scientists actually is important. And some of the stuff that people are producing is really fantastic.
How powerful this is for groups that you show a variety of responses, a variety of ways of living life, really.
Yeah, and I think it's so important what you say about the quality of information, and going back to the point that you made about blacking out faces. And we can joke about it, but I think as a patient, you look at that and you think, oh, I shouldn't be seen.
Absolutely.
And it gives you that impression. And I think I've told you this story before, that when I Googled my condition, and it was only a few years ago, but there was still very little information. And I was sort of starting to think about how it's going to affect me more because it's progressive. And one article I found that described it as insidious. And it was such an awful word. And I know, because it is the name of a horror film. And I just closed Google and thought, I'm just not going to look because it's too scary. And actually getting information that's relevant to families and isn't just the scientific information, but the sort of real life information. And we work on that now with doing condition summaries, and we work with families. And as you say, we work with clinicians to check that it's accurate, but also reflective of real life.
The variety.
And this weekend we were talking about particular words that are used to describe XLH, me and a friend, and what we like and what we don't like, and what kind of bugs us about it. And it's just checking that real life experience.
And language is so important. I mean, I still, and obviously we're doing a podcast, but I still struggle with the word disease.
I was going to ask that.
I can't even say, when we had Bill Newman on the first, didn't we? Bill Newman on the first podcast, and I went to ask him about my rare disease, and I literally I just don't see it as a disease. I don't define myself as having a disease. And I understand now, I'm mature enough to understand its language and its science, but it's hard.
Definitely. And I think there's a flip side when you hear words like correct and normal, and they do have a scientific need. There needs to be words that describe things, but then you think, what does that mean to a patient who is then incorrect and abnormal?
Yes.
How do they absorb that
And
information?
have a mutation.
Mutation, faulty.
Yes.
I read that a lot.
So can we ask both of you really whether now, after all these years of having worked with using this language, would you say that there could be other ways of describing that? Would really developmental disorder be the right words when you scientifically really maybe? Is that we are, the normality is one thing and then this is abnormal, or is it more something else?
I think society changes, and we have to change with society too. When a couple or a family or a person comes into a clinic, I always introduce myself, and I'm one of the doctors here, and then I say, how would you like, what would you like me to call you? Would you like me to call you Mrs. Smith or Mr. Smith, or would you prefer, Joanne and Anthony? And then they'll say what they prefer. And so we've established what we call ourselves. Now, you would never have done that 30 years ago. I'm Dr. So-and-so, and you're Mr. or Mrs. So-and-so. But
So there has been a change.
It's a more equal relationship, much more equal relationship, and rightly so.
And in terms of teaching, because I know you've both done quite a lot of teaching, how do you think that's going to be, the way that you're teaching with this new, obviously, like you were saying before, machines and not necessarily always family-led, how are we going to kind of remain or keep that in when we're teaching?
That's a very topical question, because Di and I are just putting the finishing touches to a new edition of a book that we do called The New Clinical Genetics, and we've been very concerned in that book to make sure that it shows that patients are people like any other people. They have certain problems depending on the condition, but they are people. And I remember, for example, that in one of the early chapters talking about chromosomes, because this is fundamentally doing the science, and a picture of a child with Down syndrome. And when the German translation of the book was done, the translators said, that's actually not a very informative picture of a Down's baby. Can we put one in of a more standard medical thing, a naked baby and so on, as we've talked about? And we said, no, the whole point of this is we're presenting this as a baby that somebody wants and loves and that is going to have its life, and it incidentally has Down syndrome. So the uninformative picture was completely deliberate and is something that we've made quite a
Yes. What you also got to do is to present the science. So you can't hide from
Sure.
the science, and you can't hide from the reality, and you can't hide from the tragedy, because there are tragedies in there too, in the story.
You say the tragedy and the science, and of course this I think I go back to my question about the disorder.
Yeah.
In the scientific way or way of understanding, is it important to keep calling it a disorder? Is it, those are, I know I'm going into philosophy maybe, but this is a genetic mutation.
We tend not to do that, because the mutation implies some sort of alien beast to a certain extent.
So what?
People, disorder means just that. You see, I didn't realise that Nicola had a problem with the word disease. I have diseases, you have diseases. It's a sort of medical term for something where there's something that's acquired. I think I know what you're saying. Because I think what you're saying is, I'm me,
And I don't need to be
and I don't need to be treated like I'm a disease, and I can quite understand that.
Yeah, and also I think even more specific that the achondroplasia doesn't need to be, from my opinion, treated.
No.
So
Yeah.
It's really interesting.
So the actual, the actual achondroplasia, like condition. I like condition.
Condition.
But I like-
Well, I was going to say
Yeah, I can't-
condition is a word that we use quite a lot in the book.
Yes.
Different.
And it's true. 'Cause
Different.
No,
We use the word
condition.
variant rather than
Yeah.
mutation.
Variant's quite nice.
Variant.
Yeah. But it's interesting because from a scientific
Variation
perspective, you
from
need
the
words.
usual.
Yes, you do
Yes,
need words
you
that have
need
precise
words.
meanings.
You need words to define things and to
Yes.
describe
Yeah.
things. That when you have a patient, you can say, this is this and this is this and this is the average and this is
Yes.
a different thing. And
Yes,
it's
it's
fine.
that language.
Yeah, finding something that suits the patients and not kind of
Yes.
demeaning.
You
Well,
see,
they're
I
actually
like
from
the
that-
word patient because that's what, I'm a doctor, and the people I see in my work, I see as patients, but not in any sort of bad
No,
situation
hierarchical
like
way.
that.
Yeah.
Whereas some people talk about clients. Well, I think, I'm not a hairdresser.
Sounds like a different service.
It's a different service.
You choose to be a client, you don't choose to be a patient.
Yeah. So that's another terminology thing, that some people won't use the word patient
Yes.
because they think that brings some sort of abnormal value with it.
Yes.
Some,
I mean, you're right. But I do agree with Sally about, and I've only recently realised this, and it's since having my children, that scientific language and that kind of very factual language can be really useful.
Yeah.
Because it can be quite reassuring even to the patients. Because when somebody's describing something to you, you sometimes have to be very matter of fact.
Yeah.
This is what's going wrong. This is why it's going wrong. And we don't need to be too polite about the language around that for that scenario.
you've got to have clarity. haven't you?
Clarity. I think that language creates clarity.
But also you can influence the outside world, if that is,
Yes.
because people might perceive you different if you consider yourself a person who walks life with a disorder
Yes.
or with a variation from the usual or whatever.
I quite like that one. Quite like being a variation from the usual in lots of ways. Not just because they're achondroplasia.
Yes, although the problem with that, of course, is that the usual is an extremely wide spectrum. So I think we would avoid that. But I would use the word condition quite a lot. We also, the word mutation is a thoroughly bad one because it means two different things, even to scientists, because a mutation can mean something that has happened to a gene here and now, like the mutations that underlie cancer. They happen in the cells that form the tumour. They are actual changes in the DNA. But you, on the other hand, have inherited a variant in the DNA. It's not a mutation in you at all. You inherited it from your parents. Sometime back a few generations ago, there must have been a mutation. But I think
So it's
in that
confusing
respect,
again,
mutation
almost.
is not a good word to
It's
use.
not accurate. Condition.
And you were talking about your global conversations before. I know Di's always travelling. She's always
Not so much.
Well, she used to be. It's always somewhere. I was always very jealous of where she was. And Andrew, I know that you are really into travelling. And how has travel influenced your work in terms of the people that you've met, either even people with conditions or colleagues who are working in the same field? How has that kind of influenced your overall work?
I guess the main thing is just it gives you a very international viewpoint. I absolutely do not see things in terms of Britain and the UK being different and special. We are geneticists. I mean, I'm very involved with the European Society of Human Genetics, and I just love the way that you meet people from so many different European countries. And I sometimes think, I mean, maybe we're in Purda and shouldn't say these things, but I think those who support Brexit or very nationalistic things, I wonder if quite a lot of them work in a field like law, for example, where, you are British-centric because laws of other countries are different from our laws. And so it's natural that your focus is on British things. And our world is so different and so international. And I think completely internationally. I don't travel as much as Di. I mean, you have to work hard to catch Di in this country.
We hope you are enjoying the podcast so far. Please subscribe, rate and review. Continue to follow our conversations where we discover that rare means different things to different people.
It does show the importance of global
Networks.
community because we're so rare that you have to, you need to become global and to meet people from different countries to learn from them.
Yeah, definitely. And even things like social media, I know it gets a lot of bad press nowadays, and there are kind of for personal use, there's a lot of things about it that I don't like, but in terms of XLH, it's been a complete game changer for me because I had never spoken to anyone or seen anyone until about 2 years ago, and then I decided to go on Instagram and talk about XLH, and then I found other patients, and then some of them have emailed and said, you're the first person I've seen on the internet with XLH, and then we get together and we have meetings, and then that's when the influence starts, because we suddenly realise that, we are there, and we do have things that we want to change.
And it's another community.
Yeah.
So maybe you feel less rare, or this becomes less rare?
Yeah, and I think that was the reason for me doing it, was that growing up I didn't have that, and my family were amazing because I'm a spontaneous case in sort of the way that they dealt with it, but I was completely isolated, and I think even
less alone.
Decisions that I made about treatment in terms of having surgery to change the way that I looked, because I felt so isolated in terms of it affects the shape of your legs, and then I think now meeting so many patients with the same presentation, I think, I don't know if I would I have made the same decision if I'd had that community that was like me, or even when I was struggling with it, that I could have spoken to someone else and said, I'm fed up today, and they can say, I'm fed up today. And then you've got that space to share.
And I know, Sally, you talked about how, when we met, how your attitude towards your condition has changed, throughout your different kind of years.
It's a bit of a, I kind of see it as a bit of a relationship, because when I was younger and I stuck to my treatment, and my paediatrician was fantastic, and my parents were really good at getting me to stick to my treatment, and I just didn't really think about it that much. I just, every now and again, I went to the doctors and had a blood test, and I didn't like it, but that was that. And then when I got older and really started to think about the fact how it was affecting me, and it was part of my identity, and thinking about the future, then that changed, and that's when I felt quite isolated, and then finding a patient community that really changed it again, and then actually being able to work with it and even further, and as I say, and it's as I say, it's progressive, and that's something that I hadn't really thought about. And I try and be quite an optimistic person and just live with it day by day and not worry, but then meeting, like this weekend I met a patient who was fantastic and also quite optimistic, but has found recently their symptoms have changed, and it's become harder, and they're having to stop doing things that they want to do, and that person was probably about 5 or 8 years older than me, but being able to speak to them, then that makes me think, okay, that's something I might need to plan for, but now I've got someone to speak to, and I've got an example of ways to deal with it, and it changes.
We're aware that Sally's got to get a train. So I just wanted to quickly, I don't know if there's two things, but I just wanted to ask about the future and from all your different perspectives of where you think genetics is going, and how it's being communicated, and what's going to be very different in the future to now.
Very briefly.
If you can, Andrew, let's start with you.
Well, I think we're moving from diagnosis into treatment, and obviously one can't treat everything, and there are things which are permanently fixed, but I think the prospects for treatment of a whole range of diseases, of genetic conditions, are very much brighter than they were even 10 years ago. And of course, that treatment will not be delivered by clinical geneticists in the clinical genetics department, but this integration into the whole of mainstream medicine, I think, is one place where it's going.
Thank you. Yeah, no, I think the same too, but I do feel that clinical geneticists and the team with them have got a particular area of expertise that they can add value to the system specialists like cardiologists or oncologists and things, because I do think that that's an area of interpretation, particularly interpretation of the physical findings together with the genetic findings, so the integration of that. I think it's changing, but I do think that, you know, at the heart of it is still a family with one or more people affected with a particular condition who are seeking information, are seeking help, are seeking treatment, but largely information to start with. And that's not changed. The families haven't gone away. So I'd still think that you need somebody who are specialists in rare diseases, but with a whole much greater host of possibilities for helping.
Yeah, I think for me, probably a bit of both. I think that if you'd asked me 3 years ago, before I knew about any of the things that were happening, I probably would have said that there wouldn't be any research into XLH or treatment in my lifetime. And now there is, and as you say, the science is advancing. But I think what will make the difference is getting all the right people together from the clinical point of view and the research, and also getting the patients there to drive it forward, and the organisations to bring those patients and all those different sides together. I think in order for those advancements to happen, we've got to get the right people together.
Yes. And it's a particular problem with rare diseases.
Yes.
Yes, so
That's this one.
And our final thing, and this is something that we're asking everybody. And it's quite interesting, their answers. And it's just, when you hear the word rare, and it's difficult, it might be more because you've got to kind of take away everything else in terms of your science knowledge, and what's the first thing or an image that you think of if you think of the word rare? What's kind of...
I guess it's really loaded for me because I deal with it all the time. I think it makes me feel as if we've got a real powerful position because we are rare, so we're the only people that can do it, which is a bit intimidating sometimes, but it also makes me feel like we've got a lot we can give.
With my scientist's hat on, I actually think of the thing, I think it was Harvey, wasn't it, who talked about experiments of nature. And in a purely scientific way, I think, gosh, we've got another experiment of nature here. Now, you know, that is not to denigrate the human side of it at all, but that's a science reaction.
I like that.
Yeah.
No, and I can understand that, but I'm looking at it from a human point of view. What came into my head was slides that people sometimes show with lots and lots of blue dots there, and then somebody with a red dot.
Oh.
Right, Di, that is ridiculous. And I'll tell you why it's ridiculous. Can I tell you why it's ridiculous?
Yeah.
And you're going to love this. That's how I described rare.
Yeah.
So it's nearly making me a bit cry. It's nearly making me emotional. I said, maybe you've implanted this in my head. Like when they asked me that question, I said I was the red dot.
Yeah.
Did
you use the same
yes.
colours?
Andrew and I continued our conversation after the recording had finished, and it was so interesting and I think really special for me to discover just how important families are to scientific research. So we would love to hear your experience with your rare condition and where you are in your journey. So please do follow us on our social media channels and join us for more conversations around rare and what it means to us all.
This podcast has been made possible by our brilliant team.
Rona McLeod,
Ramona Moldovan,
Jay Roach,
Maria-Angels Ferrin,
Nicola Garda,
Fiona Oof,
Nick Jordan.